Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today's show is sponsored by the Poway Integrative Medicine Centre, who've taken a holistic approach to providing the highest level of healthcare, combining internal medicine with alternative therapies, including acupuncture and Chinese medicine. If you're in the San Diego area, they'd love to see you, or if you're in the state of California, they offer secure video conferencing appointments when clinically appropriate. Go to PIMCHEALTH.com or call 858-312-1672. On Facebook, follow Jill Cottel, MD's page. I'd like to welcome back today my guest, who's Dr. Jill Cottel, who's one of our medical advisors. Thank you for joining me, Jill.
Thank you, Linda. It's good to be on here again.
So could you tell us, what have you been doing since we last spoke?
Well, we have a new program that we've developed over the past year where we're now doing telemedicine consultations. And it's been really fun, a whole new exciting avenue, and got to meet a lot of people who don't live in the area, and it's been really exciting. Mainly, we've been seeing people in California, and it's exciting because we get patients who otherwise may not have had access to care as quickly as they wanted, or for exactly the concerns they were looking for. It's new. It's new for us.
Mm-hmm.
Been around for a while, in other areas of medicine, but we hadn't really embraced the technology until just recently. Well,
I know from experience, when you are really sick, traveling a long distance, especially if you've got, an hour or two to travel, and then you've got to sit around in the office and then drive back home, it's too much if you're not healthy enough to do it, don't you think?
Yes, I think so. And there's a lot of people who are in that situation. They're just, not doing well, or they've got chronic pain, or, some other sort of debilitating illness. And not even that, but we're here in Southern California, and traffic is a nightmare. And so I've had patients who aren't actually that far away distance-wise, but time-wise. So they'd end up getting in the car and fighting traffic for an hour to get here.
Wow.
It's much easier for them to pull up on telemedicine, if all we're doing is chatting anyway, if it's a med check and we're just updating and mainly going to talk.
Mm-hmm. And
so that's been helpful.
Yes, and you're in California, as people probably realize, so you can do the telemed consultations in California, and you're now licensed in Virginia as well, is that right?
Yes, that's right. So either state, and it just has to be, the patient has to be in the state borders at the time of the consultation. So just somewhere within the state physically located. And then after that, their medication can be called in at the pharmacy of their choice.
Mm-hmm. Okay. Now, telephone consultations, telemed consultations outside of the US, how does that work?
Well, right now we're still trying to get an idea of that. It really depends on the country where the patient is located and what that country's particular rules and regulations are regarding doctors who are not licensed in that country. There are some countries where as long as you're working under the authority of another doctor, that's acceptable. And so it depends on patient's situation. And then, of course, if the medication is prescription or if it's over the counter, that makes a difference too for the various countries.
Mm-hmm. Now, excitingly, imminently, the LDN app is going to be tested in about 10 days' time. And we've altered it so that patients, doctors and pharmacists can monitor their patients. Now, I know this was going to be of particular interest to you because you have been prescribing not just the low-dose naltrexone, but the full-strength naltrexone for alcohol use disorder. Could you tell us how that is going to work and how the app comes into play?
Yeah, so we're very, very excited about being able to use the app now. And we do a lot of work with patients who are seeking treatment for alcohol use disorders. And the telemedicine is nice because it's easy, it's private, it's discreet, and patients who are in all areas of the state have access. There are different ways that patients can keep track of their alcohol consumption, and they can use an Excel file or a personal journal, but the difficulty is getting that information to me or to their provider. And now with the LDN app, there's a way in there to actually be able to log the consumption of alcohol on a daily basis. And there's other places in the app to log other symptoms like sleep and pain and quality of life and things like that. And so for patients to be able to share that information with us so we can pick it up on our end, I think is going to be huge.
Mm-hmm. And I have spoken to several people who have an alcohol problem, and they find, the ones that I've spoken to, is that they are unhappy with themselves for doing it, for being addicted to alcohol, and they are ashamed of people knowing. You know, they don't want to go to Alcoholics Anonymous. They don't want to even go to their doctors to say, I have a problem. But in your experience using what's called the Sinclair method, how successful has that been for your patients?
It's been very successful. I would say if you look at what's reported with other clinicians using it, and in the literature, it's somewhere around 70% success rate or higher. And in our practice, we've seen about the same rate. I would say maybe 3 out of 4 patients are successful. And we can often tell in that initial consultation if they're more likely to respond. So if they're patients who've had a family history of other family members with alcohol issues, if they have strong alcohol cravings, and interesting enough, if they're craving sugar. So those things tend to suggest they have endorphin-mediated alcohol drinking problem. But those patients tend to usually respond very well. The naltrexone at the full dose, at the 50 milligrams, and sometimes you have to go a little bit higher, but generally around those doses will actually block the endorphin pathway to where it's not that they won't feel relaxed and have the normal effect of alcohol, but it won't have this endorphin reinforcing effect, so that over a period of time, they no longer have any difficulty controlling their consumption, and it's not something that is a problem in their life anymore. Because for the most part, it's not the alcohol that's a problem, it's the patient's response to the alcohol and what happens with the wiring in their brains. And so that's what we're trying to address.
For those people that don't know what the Sinclair method is, could you just explain, because where normally if you have an alcohol problem, you're told you're not to drink. With this program, you're still able to drink. So could you explain the steps that you take and the patient takes when they first start with the naltrexone?
Sure. So this has actually been very well documented in the literature. It's been studied. It sounds unusual, but there's good literature and documentation for this, and I reviewed this in the recorded talk we did for the last conference. But in the literature, it's called targeted dose naltrexone, and it's where patients are not abstinent at the time they begin therapy, which is in the past was not typically the case. Normally, patients were required to become abstinent before starting any sort of program. In this program, it's not a requirement. And patients are begun on the naltrexone while they are consuming alcohol. And what we find is that if they're a patient for whom they're a responder, their consumption will just gradually drop with time, usually within the first month. And so they end up detoxifying on their own. So they're not going to an expensive rehab program where they pay thousands and thousands of dollars and have this sudden withdrawal with all the symptoms that go along with it. It's very unpleasant. This way they're, in the comfort of their own home, able to keep their own schedule, go to work, but gradually that consumption's coming down, and so they're not going to have the acute withdrawal that other patients are going to go through. And by having the naltrexone in the system when the patient consumes alcohol, it's blocking the reinforcement effects of the endorphins that are given off when they drink. And then over time, that pathway that has been built into the brain that is causing the patient to have problems controlling their consumption, that pathway is actually being extinguished, is what it's called in the literature. And if a patient has endorphin-mediated drinking, it's actually very effective. And then after a certain period of time, which is anywhere between 3 months and 6 months, the patients can go on from that point and be abstinent if they choose, or they can be a social drinker. We just recommend that they always take the naltrexone before drinking so they don't develop this sort of problem again. Mm-hmm. Now, interestingly, I think that there may be a role for low-dose naltrexone in maintaining these patients once they've gone through the first phase of treatment. And I say that because we've had a few patients who we actually had to transition to low-dose naltrexone down the road for other medical problems, and they actually were able to maintain the success that they'd had with that, with the program. And I think there might be a role for it in helping with the endorphin levels.
Well, that's interesting.
So I'm finding that interesting. And because, you go for 3 to 6 months on the standard dose naltrexone, and you are suppressing the endorphins. And so we don't want that to be a long-term treatment where you're going to take one tablet of 50 milligrams naltrexone every day forevermore. So, if patients are drinking a couple times a week or here and there, it's probably not an issue. But in the in-between days, taking low-dose naltrexone to kind of help boost the endorphin levels seems like it would be a reasonable thing to do. And there's no literature for this yet, but from the patients, the very early responses we're seeing, it looks promising.
Mm. And for any of the patients that you have treated, have they relapsed or have they all followed the program?
So we've had some patients where they have decided they're completely better and don't need to worry about it anymore and stop taking the naltrexone altogether too soon. So some patients, we had someone at a month who just felt like they were cured and went off the program, and it was too soon, and they ended up relapsing. And then we've had patients who were not quite finished, who, for whatever reason, went off the program and stopped taking their naltrexone and ran into some issues. But the good thing is a lot of these patients will contact us and say, hey, fell off the wagon. I want to get started back on the program. They get started back on it, and then they're successful.
Mm-hmm.
So,
well, that's good.
That's been helpful. And there are accountability groups that are non-abstinent based in our area. I can't speak for other areas of the country, but there are some of these springing up, and there's starting to be more people who are supportive of this approach. And so if patients can kind of have some support through this, I think that makes a big deal of difference.
Mm-hmm. We supposedly in England have a problem with binge drinking. They show you pictures on the television and in the newspapers where youngsters are good all week and then at the weekends they just drink themselves silly, where they can't stand the vomiting and so on. If they were to, obviously it's not good for you and you're going to get addicted to the alcohol, but would the targeting dose naltrexone stop the binge drinking?
So there is literature to support that it is effective for binge drinking.
Okay.
So there is literature to support that. And it's interesting you bring that up about the young people because it's a huge problem in this country as well. And our young people are very affected by alcohol use, heavy drinking, and binge drinking in high school. But what we found, my initial thought was, so if we could somehow work on prevention, so target the children of the parents who have had alcohol use disorders and try and catch them before they develop a problem. So perhaps giving them a prescription for naltrexone when they go off to university, and just explain, look, we don't want this to happen to you like it happened to us or like so-and-so in the family, and just take this beforehand. And we're not condoning the activity. We're just saying if on the case that you were to drink, make sure to take this first. But the problem, looking at that, actually, the patients that we're seeing coming through this program, many of them have started drinking at 12 and 13 years old. And it's just so young. It concerns me that patients are getting into their later teens and they've already developing the problem, and prevention is almost too late at that point. We had a patient just very recently, first drink was at 12 and they were drinking regularly by 15. And then some of these patients are having serious life consequences as early as high school. And we're not able to get them. So there needs to be more, definitely our work cut out for us in reaching that demographic.
Wow, that is so young.
Really it is, and it was surprising. It was surprising. The first set of data that I read through and presented in that talk, I want to say the ages went down to 14. At 12, it's so young. You just wouldn't think about it.
No.
And I think about my children when they were 12, and it would never have occurred to me that their friends are drinking. But I know that here in our middle school, alcohol is sometimes being brought to school. So it's out there. It's more common than we think.
Well, if you're drinking that young and you have a problem, you're not going to be able to study, which in turn means you're not going to get very good qualifications, which then is going to impact on all aspects of your life, isn't it?
Right. Yes.
Well,
affecting the grades and your ability to get into university or your ability to get into the vocational school or the job of your choice. It's just, problem all the way around.
And of course, if you're drinking excessively, there's all that sugar, which is going to cause weight gain, diabetes, the list goes on, doesn't it? And how do you support buying the alcohol. How easy
Right.
is that, and the cost of it? If you were a school pupil,
Right.
you're not earning a salary, are you? Yeah, that would be a good thing to be able to do, but I could see it would be quite a tricky thing to achieve.
I think the more that we can get adults treated. So right now it's not something that people really want to talk about. Like you were saying, they're embarrassed to talk to anyone. Often I'm the first health professional they've ever talked to about it. Their doctor doesn't know, their family doesn't know, their clergy doesn't know, nobody knows. And so certainly their children aren't going to know. But if we can get this out into the open and say, hey, we have a medical problem. So yeah, there's lots of different reasons for drinking. But there are particular cases where this is a problem with endorphin-mediated drinking. It's a physiological problem. It needs to be addressed as a medical problem. Nobody is embarrassed to go to the doctor for asthma, or high blood pressure. An alcohol use disorder is a medical problem. Let's treat it medically. And then I think once people get more comfortable with this model, children can see the example that the parents are setting. The parents are addressing a medical problem. Once we can get that mindset changed, I think they can model it for the children. That's what I'm hoping anyway.
So just quickly, you were talking about using LDN in the in-between. What would you say the intake of alcohol is for people on LDN? Have they noticed a decrease in the desire to drink alcohol?
So I have not used LDN per se as an initial treatment for alcohol use disorder. And in my patients who are taking LDN for other purposes, I don't know that has made a difference in alcohol craving. But, it's a very good point because it's not something I routinely ask.
No.
But we'll see this on the app now.
That's just what I was going to say, because I've never been a drinker anyway, but if I had wine at a meal, I could drink a couple of glasses of wine and, that was all I wanted. But since being on LDN, that 2 glasses is 1 glass. And after I've had 1 glass, I really do not want another glass. I would rather have a cold drink of some, a soft drink, but not the alcohol. And I have spoken to other people who have found they don't have an interest in alcohol anymore.
Yeah, it'd be very, very interesting. We do have patients who report they don't have certain food cravings they used to have on the low-dose naltrexone. And it's interesting because, a lot of patients who have these autoimmune diseases, rheumatoid arthritis and so forth, they have chronic pain. It could be they're taking in more alcohol than we know. And we know from the studies in primary care, we're not asking about alcohol as often as we should be. We're not screening for it. And so there may be people on the app that will pick up that we never asked them about their alcohol use because we were so focused on their arthritis and asking them all the questions related to their autoimmune that, we didn't get a full alcohol history. And so maybe when they're going through the app and they see the alcohol page, they'll fill it in and then that data will be picked up. That's actually, I hadn't thought of that. That's fascinating.
Well,
that's exciting.
We can keep learning all the time, can't we? But
I think so.
Our time is up, Jill. It's always so wonderful to speak with you. We'll have to have you back.
Oh, thank you.
Again in the summer or sometime, and find out how you're getting on with the app and tracking your patients.
That sounds wonderful.
And thank you.
I'm looking forward to it.
Good. Thank you for joining us today.
Thank you, Linda. Bye-bye.
Today's show is sponsored by the Poway Integrative Medicine Centre, who've taken a holistic approach to providing the highest level of healthcare, combining internal medicine with alternative therapies, including acupuncture and Chinese medicine. If you're in the San Diego area, they'd love to see you. or if you're in the state of California, they offer secure video conferencing appointments when clinically appropriate. Go to PIMCHEALTH.com or call 858-312-1672. On Facebook, follow Jill Cottel, MD's page. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.